So thank you very much. It's a little bit difficult to speak after these wonderful talks, and I'm going to talk about something perhaps a little bit less sexy, since it's not research, it's really the clinical care, routine clinical care of these subjects in our clinics. So just as an introduction, you know that we have been increasing our knowledge in genetic ALS, that now we have a treatment that works decently. So we systematically screen all the ALS patients. So we are discovering a lot of at-risk populations that they are coming back to us, and that confront us clinicians to something that we didn't really thought about that before, is that clinical care goes beyond the affected ALS patients to expand to the at-risk relatives to these patients, which raises, of course, complex challenges. So in the Pitie Salpetriere, my professor Dur, I've been seeing these subjects for 8 years now, and roughly from 350 subjects, I know about 130 carriers. So as you've seen, the numbers have been increasing and perhaps have reached the top, I don't know, over the last years for about 50 to 60 new subjects every year. And I systematically ask them why do they want to come and do the test, and why there are other motivations for asking for genetic testing. And what the most common answer is to know. And one might project a lot of interpretations on why they want to know, but if you really ask them, why do you want to know? Most of them, the only thing they can think about is to be relieved from the anxiety of not knowing. So it's like an entity to know. And afterwards come to inform the children, because as Professor Duercer said, many of these people are already old and they have own children that want to know their status, their genetic status. Some of them come to be informed of reproductive choices they may have if they are carriers. And very more anecdotically, they ask for other motivations. Research, early access to care, or sometimes because I think they have symptoms. So as you see, early access to care is not the main motivation why people are coming to us. They want to know, and they want to be relieved from this anxiety. And when we see them, this information phase that was described from Professor Dior, we very much emphasize the fact that we may release this first uncertainty, but we are going to open, if they do carry the pathogenic variant, we are going to have a lot of more of uncertainties they will have to live with their whole life. We don't know if they're going to get the disease. If they get it, we don't know when, and we don't know how. So these people, we disclose to them the fact that they are at risk, but it's possible that they're going to remain their whole life, many, many years, and possibly their whole life under medical observation if they accept the routine clinical follow-up that we are offering them. So that's something to consider. Of course, the fact that they are coming to us and that we know that they exist and who they are is a huge benefit for the research community. And I don't have to explain how important the study of these individuals is, and how much we would like to find a way to know what the optical therapeutic window will be when we will have, and we hope we will, specific treatments for every genetic form of the disease. But now we are considering the clinical care. So we put aside our research objectives, and what matters is what the people coming to us want and what their needs are. So with that perspective, I'm going to talk about this phenoconversion, and the question that I ask myself and I ask to all of you is what is clinically meaningful in this context of routine follow-up. So I'm going to focus on motor for the phenoconversion for the same reason Thomas Maya said he was talking only about motor with this OPM classification. It's because it's easier to get a consensus for the more hard finding, which is the motor phenotype that the patients could have. And it's interesting because I'm showing, again, the same figure from Michael Benatar you've already seen so many times, but I'm going to use it in a slight different way. So just to say that there's still no consensus about how do we see things and what exactly this phenoconversion is. We could all agree that there's not an on-off problem. It's a transition, so that's okay. And if we start at the beginning, I think we can, it's also the easiest part to talk about the asymptomatic, what I call asymptomatic. That is no evidence of disease. And for me, these are subjects that carry a genetic characteristic that expose them to the risk of disease, but they're not ill. They may become ill, they may not, as we all carry many genetic characteristics that we are aware of not, and then that predispose us for risk of cancer or thyroid or whatever. So no symptoms of disease, clinical, no symptoms of disease if we search for them in paraclinical examinations, and no evidence of biomarkers. And although we still do not have a lot of pertinent biomarkers, but we may at some point, so complete asymptomatic. And the opposite, and the other way, is the disease. That's also quite easy to get to a consensus, and we talked about it in Frankfurt. I think we all can agree that when we're talking about ALS, motor phenotype, the disease comes when weakness comes. But still we have to define what is a sufficient weakness to say that the disease has come. And for me, it has to come with some kind of time progression. So it's a weakness that was not there before, that comes new, and probably that is progressive, that should be coherent with the disease onset, not a generally weakness, and that is not explained by another cause. So it's not automatic. You have to think a lot about the presentation and perhaps do some exploration and see the patient afterwards to establish that it's a disease making the onset of the disease, so the phenoconversion. And in between, that's where the trouble is. So that's what I call the gray zone. And the gray zone is not asymptomatic, not only carrying a genetic characteristic, and not ill, but something in between. And now, and I suggest, but of course we can discuss, that it can be cut in two, as Michael Benatar already designed in his diagram, in two phases. A presymptomatic phase, and now the use of the prefix is legitimate because although there are no symptoms or signs of disease, it's completely silent clinically, but they might be relevant biomarkers that are still to be found. But still, we can find something that tells us that the neurodegenerative process has already begun. For SOD1, it would be the neurofilaments, but we still have to find it for the other gene, for the other genes that can give rise to ALS. And the second part of this gray zone is the prodromal, where the people are beginning to complain or something, or not, or you can find something when you do a thorough neurological examination. And that is much more difficult to define and to be sure that we are really into something prodromal that is that tell us that we are just approaching by very near the disease onset. So Michael Benatar, of course, has worked about it, and he has very recently proposed this research criteria for this mild motor impairment, which is the equivalent of motor prodromal syndrome. And I'm not going to detail it, but I'll say it's for research purposes. So for my point is we cannot use that for routine clinical setting for many reasons. The first one is that he did his study that has a lot of SOD1 carriers. Most of them are R4V, so very different populations for the ones we are following. So we don't know how good we could generalize these findings to other genotypes. There's also some overlap with normal variation. what you can take into account when you are in a research setting, of course, because you can control and do statistics afterwards. But in a clinical routine setting, you are one-to-one, facing one person who's asking you a very specific question, and you're going to give an answer for this person specifically. And most importantly, we don't know yet the predictive value and what is the temporal link to a clinically meaningful phenoconversion. So for me, in a clinical setting, we cannot use this kind of criteria until we have better and longitudinal data and more data that will allow us to apply this definition of prodromal disease in a clinical setting. So this gray zone, for the moment, is too much uncertain. And the risk of maleficence, when we tell a subject that he's coming to this gray zone, and we don't know, in fact, what that means, how long is it going to stay, and more importantly, there's no benefit possibly, because there's no treatment, and we can talk about the exception of SOD1 afterwards, but for me, the gray zone should not exist in this routine clinical care. So for me, there's no indication for routine investigation to detect this gray zone because we don't know the meaning of it and we wouldn't know what to do about it. So I was talking about this motor phenoconversion, but if you see, that's the diagram of my asymptomatic carriers, and you see that it's very much enriched in C9 population. So these C9 carriers have a risk of motor phenoconversion, but also of cognitive and behavioral symptoms, and also extrapyramidal symptoms. So that is a new complex and not really well described zone for this prodromal and gray zone I've talked about for the motor syndrome. So that adds a lot of complexity. And although there's a lot of literature from the FTD world for the mild cognitive impairment, for the extrapyramidal impairment, we really don't know what to do about that. So just to say that's a lot of work to be done. And then I thought I could just present some cases of how it looked like in the clinic when they phenoconvert. So the first individual was is actually a 62 years old man. He carried a C9 expansion, and he had testing when he was 56 years old. He wanted to know, as many other people. And a couple of years later, he started to come to me and saying that he had very, very bizarre sensory complaints. It was tingling, it was pain, it was burning, without any systematical topography. But the neurological examination and the motor examination was completely normal, so nothing was done. And very few weeks later, he fell, and he had a femoral neck fracture. So I said, okay, I have to do some exploration. So I did, and I found nothing. And I continued to follow him, and he was still complaining about this sensory, and it was aching, and I couldn't really make something about it. So I sent him to this cognitive clinic, and he reached the threshold to be prodromal FTD. Okay, and so when the carriers become this diagnostic of prodromal FTD, they say to them, okay, come next year and we'll see if it gets worse. So in between, he came back to me, and again, the sensory disturbances. And he was complaining of this imbalance when walking. So I did the MRI again, cerebral MRI. And it appears that he had in between new lesions that were inflammatory. So he had MS. And I started on rituximab, and he's doing better. So don't neglect the possibility of other diagnosis, even if a prodromal FTD is blurring all the symptoms. So still asymptomatic for the motor phenotype. Another example, 60-year-old woman, SOD1 carrier. She come to the testing, she was 66-year-old, and she said, I do the test because I want to know for my children, because they want eventually to do the test and know if they're carriers. So during the process of information, the consultations, she complained of anything at all, but I could see very clearly that she had an amyotrophic deficit on her left hand. But she didn't mention at all, so I didn't mention at all either. So she did the test. I know she wanted to do the test, so she did it. She was a carrier, and when I saw her afterwards, I started to talk about the fact that I saw that her hand was a little bit amyotrophic. So it took a couple of consultations that she accepted to do some more examinations about that. So at some point, she accepted the diagnostic workup, and it confirmed the evolutive lower motor neuron disease. So the diagnosis was made. And on the follow-up afterwards, she has a lot of insight, so it's very nice to speak with her. And she really explains very, very clearly this ambivalence about this official entry into the disease. She's not quite convinced that it was a good thing for her that we qualified this slight amyotrophic deficit that does not impact her autonomy as the disease, and she still doesn't want tofersen. So we may be eager to make a diagnosis, but the affected individuals may be less eager to receive it. And the last case, it's a 58-year-old woman, also a C9. And she did the test 3 years ago. Sorry, it's a man. 3 years ago, he had no complaints. She said he wanted to do the test to inform his daughter of her risk. And everything went as normally. And, but he didn't want to come to the clinic because he lived quite far away from the Pitie Salpetriere. So at some point he requested a video consultation that we had, and he reports to me a very strange episode when I really, I remember very clearly, it took me a lot of time to make him describe exactly what he was telling me about what happened with his left hand. And he said that the fingers was slightly moving. Well, it doesn't resemble anything. And then at the end, he said to me, I did acupuncture and everything went away. And so I said, okay, it's all right, I'll see you next year. And he didn't present next year, the year afterwards. And then he came back to me and said, I have difficulties walking. So I see him in the consultation, and he has a completely declared 3 regions motor neuron disease. So I gave him the diagnostic. I ordered the workup because it was really, the clinical picture was enough. So I ordered the workup and organized a multidisciplinary clinic care, and he doesn't come. And he started, and I received letters from other specialists, and he decided to go to the here or doctor because of the dysarthria. He thought she had some kind of problem in this local problem. So I already talked about this case. It's a paradoxical situation of there was a diagnostic wandering after the diagnostic. So it's kind of surprising to see that the diagnostic delay is not necessarily shortened by this asymptomatic testing, because although we may know, they perhaps do not want to know. So that's a work we have to do. How we do prepare them at best, or do we have to push them to accept? Perhaps not. I don't know. We have to think about it and talk about that. So in conclusion, there's an interplay between research and care that is very obvious and that we need. But not everything is really can be taken directly. we have to think about what we are doing, and we have to think that in clinical care, we are the doctors of people that put their confidence in us to take care of them. So the interest of these individuals seeking medical advice should prevail at any time of our desire to know, to make a very fast diagnosis, to give them very fast every treatment. And with that in mind, we should refrain to overinterpret subtle clinical signs or symptoms that for the moment we don't know what the meaning of them is, and that may represent for the carriers a very, very high psychological burden that we may not be able to manage. So for me, there's no indication to seek and even less to disclose prodromal stages, with some exceptions. Of course, the very fast SOD1 variants and some fast variants, of course, I will agree to that, but for the other genes, and we need further research and very thorough longitudinal follow-up with a higher number of carriers to better understand the implications of the findings, of these subtle findings. So thank you very much.